Hello, I'm Stephanie Hightower, the President and CEO of the Columbus Urban League. Colorectal cancer is the third leading cause of cancer death in the United States. But there is some good news. The number of new cases and the number of deaths from colon cancer have been decreasing over the past 2 decades. According to experts, that's likely due to colorectal cancer screening programs. While some of these overall numbers are encouraging, colon cancer disproportionately affects the Black community, where the rates are the highest of any racial ethnic group in the United States. African Americans are about 20% more likely to get colon cancer and about 40% more likely to die from it than most other groups. Joining me today to discuss colon cancer, including its impact on the Black community, are Dr. Leila Conte, a gastroenterologist and medical director of endoscopy and gastroenterology services at The Ohio State University East Hospital, and Dr. Matthew Kalady, a colorectal surgeon at the James and the director of the Division of Colorectal Cancer at The Ohio State. So thank you for being here, and I'm really excited about this conversation today. Very important to the constituency base that we serve at the Columbus Urban League.
Absolutely.
So let's start off, Dr. Conte. What is actually colorectal cancer, and why is it so important for people in the minority groups to take screenings for CRC? Why should they take them seriously?
Absolutely. Thank you for that question, Stephanie. So I think it's so important first when we talk about colon cancer to really make sure patients understand what is the colon, right? And I bring that up so everyone has a colon, men, women, children, and adults. And colon cancer starts in the colon, which is the last part of the GI tract, the digestive tract, where our stool exits. And usually it starts as a clump of cells, and over time, those cells may grow to become colon cancer. But the reason why I mentioned the first part, I remember being at Ohio State East Hospital. This was some years ago, and a woman had brought her husband in to get colon cancer screening done, to get a colonoscopy. And she said to me, "Oh, this is just something that men get, correct?" And I said, "No, you have a colon as well. This is something men and women, everyone should get as an adult." And we'll talk about some of the risk factors, but I think important to send that message out there to our communities that colon cancer affects men, affects women, and everyone should be getting screened, not just men.
You know, you are so on point about, especially in the Black community,
Yes.
that misnomer that only men get a colon cancer. So Dr. Kalady, tell us, what is a colonoscopy? Because I think, a lot of times people really don't understand why it's necessary and how that helps you to identify colon cancer.
That's a great question. I think the first thing is the key to colorectal cancer, both treatment and prevention, is that colorectal cancer is one of the few cancers that truly is preventable by doing screening at the appropriate time and getting the right tests. As Dr. Conte said, you get these little kind of lumps or bumps of cells, and those cells become a little bit more, have more changes to them, and then eventually they become cancerous. Those lumps or bumps are called polyps, and you could take those polyps off before they become cancer through a colonoscopy. And if you get rid of that polyp or get rid of that lump of cells, that area doesn't have the risk of getting cancer anymore. You can get other things other places, but the colonoscopy is one of those procedures that you can go make an intervention and actually prevent cancer before it happens.
That's pretty, and I didn't know that. So I'm learning something today too, that it is actually curable. And I think people need to really hear that it is curable. That's a lot of times when you hear cancer, people are like, "Oh my gosh, I'm getting ready to die." But to hear that, thank you so much for identifying that. So Dr. Conte, tell us, what are some of the causes of colon cancer?
Right. So I think that's one of those questions in medicine that we're still trying to pinpoint and say this is exactly what it is. What we know, even though we don't know the exact cause of colon cancer, we know that there are risk factors. And that's what, when we talk to patients, we can really have a discussion around is, what are those risk factors for colon cancer? So many different things. So we know older age, which is why we recommend starting screening at a certain age. In the United States, now that age is 45 years. So everyone, men, women above 45 and up should be getting screened for colon cancer. So we know age is a risk factor. We've talked about African American race being a significant risk factor. As you mentioned earlier, we know that African Americans don't get colonoscopies at the same rate that other people do. And we know that when we do get diagnosed with colon cancer, we're diagnosed at later stages of the disease and tend to have more deaths from the disease. So race is a risk factor, age is a risk factor. We know that diet is a risk factor as well. So unfortunately, the American diet that's high in fat, low in fiber, we know that that's a risk factor. And we know that for people who follow the Mediterranean diet, for example, that can be protective against colon cancer. And there are some other conditions as well, and Dr. Khalidi may touch on this, some conditions that are inherited that put patients at risk for colon cancer. And there are certain conditions like inflammatory bowel disease, Crohn's disease, ulcerative colitis, that also puts patients at risk for colon cancer. But so important to have this conversation so we can talk to patients. What are those risk factors? Family history is also really important. Making sure that we address those risk factors and advise patients about getting screening at the appropriate time.
So, Dr. Khalidi, if there is someone or a patient that they found out that they have some form of colon cancer after a screening test, what then is the process for them?
Sure. So there's a big network of physicians that go through. So usually you'll get diagnosed most likely by your gastroenterologist or a surgeon who does your colonoscopy. To get back a little bit, so what is a colonoscopy? A colonoscopy is a test where you look with a small instrument. It's a camera on a long instrument that goes into the bottom after a prep and clears everything out, and it actually visually inspects the lining of the colon all the way around to where the junction of the small bowel and large bowel meet. So that's usually how it's diagnosed. There are some other screening tests we can get into, but the ultimate way to diagnose cancer is to take a piece of that tissue, look at it under a microscope, and they say, yes, this is actually abnormal enough that it's a cancer. So once that happens, then whoever got that test or did that test for you will refer you on to a surgeon usually as the first step. Colon cancers and rectal cancers are treated a little bit differently, and it depending on what stage they are, meaning where are they? Are they just located in the colon? Has it gone somewhere else in your body? Where is it located? Those kind of things. Can be anything from surgery by itself to getting maybe chemotherapy to maybe get radiation even before surgery, depending on where it is. So getting all those people in the right place and having a team together is really, really important. The surgeon usually is the first point of contact for those because we'll do what we call a workup or a staging evaluation where we get CT scans usually or images of the chest and the belly and the pelvis to see if it's gone somewhere else. We do some basic blood work. And if it looks like it's just in the one spot, then usually surgery is the first step. And then after that, we look at everything and say, where was it after we did the operation, when we took it out, and we do a stage, a pathologic stage, which means basically looking again under a microscope, how deep it's gone into the wall, were there lymph nodes that were involved, other things like that. And then from there, we can decide, okay, based on this and based on studies that have been done with thousands of people, we know you'd benefit from the next treatment, which might be chemotherapy, or you might be completely treated with surgery alone. And then you go into what we call a surveillance program, where we keep things under close watch for 5 years. And we see somebody maybe every 3 months just to check in, see how they're doing, get some lab work, get intermittent imaging, get a colonoscopy again, just to kind of keep a close check on everything. But again, if we get this early, it's something that's curable.
So are you taking off polyps or is there a whole, when you're doing that surgery, what does that actually mean?
Sure. So if it's just a polyp, it can be taken out just with the scope usually, and then it's completely gone. But if it is a cancer, usually treat cancer by getting more of the colon. So the colon it kind of goes around, almost looks like a question mark. It kind of comes up your body and around and out the backside. In the middle of that question mark, or the middle kind of spokes on a wheel, live your lymph nodes. And the blood vessels all go from the center of your body out to this part of the colon that's around your body. And we know that if the cancer is in a certain space, it has certain things on either side of that tube, if you think of the colon as just a tube, where it can spread. And then we know that it spreads to lymph nodes. So we don't just take out that one spot. We take out on either side of the colon, usually for a couple inches, and then all the lymph nodes that drain that area. So we kind of take a wedge of the pie out, and then it's just like plumbing. We put the pie back together again. So we hook up that wheel, the two pieces of valve, we sew them back together again. So you lose part of your colon, but you still have enough left to process and have normal function and other things.
All right, interesting. That is really good to know. So, let's talk a little bit about a lot of people don't like to talk about, number one, cancer in the Black community, but then if you're talking about colon cancer. So we know that there are a lot of health disparities for people of color, and a mistrust sometimes of doctors. How do you, Dr. Conti, how do you begin that conversation? What do we say to folks in the Black community about how do we need to start having this conversation?
Yeah. I think something that you've both mentioned, the important part of all this, we can talk about cancer and treatment, but our goal is to try to prevent people from even getting cancer. So I think trying to get that message across, yes, we can treat cancer, and people like Dr. Khalidi can do it very, very well, but let's try to prevent you from getting cancer. And here are some things that we can do to prevent you from getting cancer. It's one of the few cancers, colon cancer, that we can prevent, as we talked about earlier. So I think really trying to get that message of prevention across, of here's what we can do. And what I tell my patients, colonoscopy exists and we're very good at it. I do them multiple times a week. However, there are other tests as well that we can do. The most important thing when we talk about screening for colon cancer, the most important test to do is the test that the patient is going to get done. So making sure that the patients understand colonoscopy is one part, but there are potentially some simpler tests that we can do that can screen you for colon cancer as well. It may be that if those tests are positive, then we do need to go to a colonoscopy. But I think we can get patients on board by really presenting them all those different options and really getting on their level and saying, we can prevent this, and here are the things that we can do, here are the tests that we can do to try to prevent this. Or if you have it, let's make sure we catch it early where we know that we can cure it.
So when you're talking about catching it
Yes.
early, what are some of those symptoms that if somebody, if we're talking about prevention here, what are some of those symptoms?
It's a little bit scary in a way because sometimes you have no symptoms.
Correct.
And that's why we say at a certain age or at a certain thing, that's when you get your screening done.
Right.
So the average age, or not the average age, the age that we recommend to get screening now is at 45, even if you're completely asymptomatic or have no symptoms at all. The other thing is if you do have symptoms, then you need to get evaluated. I always tell patients, no amount of bleeding is normal. Something's causing it. And then it's, it's just a hemorrhoid. It's just this, it's that. And they just blow it off. Yes, hemorrhoids do cause bleeding, but also other things cause bleeding. Hemorrhoids could also be treated. So it's important to have that conversation. It's an embarrassing topic sometimes. People don't like to talk about their bowel habits or about bleeding or any kind of things. But any kind of bleeding should be evaluated start with your primary care doctor.
Right.
If you have a change in your bowel habit, say you go, you're normal, you're regular, and all of a sudden something changes. You're a little more constipated or you're having diarrhea or you have trouble getting things out. Anything that's a change. If you're getting more tired, if you're fatigued all the time, you get exhausted, any of that, you're losing weight. Those are all kind of signs and symptoms. It could be anything, but also you have to think about that. So I think it's very important for our primary care physicians in the community, because they're the ones who are getting face-to-face with our patients the most, to every opportunity, ask them if they're having certain symptoms. Right. Tell them that these are symptoms. If you have any of these things, let us know about it. Because otherwise people just tend to blow it off, and people don't like to go to doctors, and we know that.
Exactly. And I'm from a lower, just say I'm from a lower socioeconomic group, and so I don't have a primary care physician, right? But I'm experiencing some of those symptoms. So can someone just go to I hate to say emergency room, because I know, everybody goes to the emergency room with something, but if I don't have a primary care physician, right? If I don't have healthcare insurance, that's one of those big issues, I think, why we see those numbers are so high still in the Black community. So if you're having these kind of symptoms, what would you recommend if somebody's having some symptoms like, blood in their stools? Is that should be did I hear you say that should be an immediate trigger for them to go see someone?
It's a trigger. It doesn't have to be an emergency. If you're having a little bit, there obviously various degrees. If there's a lot and it's scary, yes, go see somebody right away. There are emergency departments. If there's health centers, if there's walk-in ambulatory places, and anything like that, any kind of healthcare is a good start. See anybody that's accessible, and then those people can help get you into the system, get whatever's done or needed to be done, and then hopefully get you to the right people from there.
Is there any genetic testing? So say if I know that my mom or my dad or sister or brother has had colon cancer, is there genetic testing that you can do?
Sure.
Yes, by all means.
There absolutely is. Everybody is born with a set of genes from mom and a set of genes from dad. And those genes do everything from your eye color to what your weight's going to be to are you going to get cancer in certain things. So about 5% of colorectal cancers actually develop within a hereditary syndrome, which means that risk was inherited down from mom to dad, or mom or dad to their son or daughter. The things that put that at risk are someone who has cancer at a young age. So when they're 40 or 30, or even I've seen people in their 20s, unfortunately, that have cancer. And that's not a normal progression. So there's certain red flags that we see that those people should get tested. Once we test, there's a panel of genes that we know, or parts of your DNA that we know actually if you have a abnormality in those genes, that you are at risk. And some of those genes actually give you a 100% chance of getting colon cancer in your lifetime. Right. Some give you 40%. So it's a very real phenomenon. The key is getting that person who is affected or has the cancer, getting them tested first to see if they have something. And then if they do have something, it's a simple blood test, and we get the results back. Every one of their first degree relatives, meaning every brother or sister, their children, their mom or dad, has a 50% chance of having that also. So once we know what they have, every first degree relative can get tested. And then it ripples out from there, because then that person has first degree relatives, and that person. So for every one person we identify with the syndrome, we identify somewhere between 3 and 7 more people who have that gene as well. And again, it's prevention where it's really, really important. If someone has 45 and they have it, and we find out they have this disease, that person might have children who are 20. And we actually start screening people at 20 with certain syndromes, or even younger. So now, instead of getting a colonoscopy at 45, they get a colonoscopy when they're 20, and we find something we would never looked for before, and we take the polyps off before they become cancer and prevent them from getting cancers. So having the genetic testing is really, really important to identify those people and intervene for people who don't have anything yet.
Wow. So, again, these are really uncomfortable kind of conversations we know for a lot of families and people. So what would you recommend? Like, where do people begin? How do they begin to have those conversations, Dr. Conte?
Yeah, I think for us, it's normalizing some of those conversations. I think when we see patients, making sure this is what we see every day, but understanding that for the patient, this is not what they do every day. This is not what they deal with every day, but let's normalize it for them as much as we can. So when we talk about family history, for example, with colon cancer, in the African community, many of us don't talk about our family history.
That's right.
Right? Many of us do not talk about it. Mom or dad may have hypertension. They may have diabetes. They may have one of these genes that Dr. Khalidi just talked about. That information is not shared because there's a stigma associated with it. So I think as healthcare providers, and really for all the community, let's normalize some of those conversations about family history and help people to understand that if you know this, tell your sister, tell your brother, tell your child, because you may prevent something from happening to them down the road. So normalizing and making sure that we're asking about family history, I think, is a place to start.
So how do we get away from the stigma, Dr. Khalidi, of that, the procedure? Because I think that's a big, I mean, my fiance, I had to just about drag him in. And this is a 50-something-year-old man. I mean, how do we get away from that stigma?
You're right. It's a huge stigma. People don't want to do it.
Right.
But I think, one, you got to get the message out. What's the value of doing this and why we're doing it? And it could save your life or your family's lives.
Right.
The other thing is, when you actually get the test done, most of the time you're sedated or asleep completely. And
Would you say that again for people that didn't know that?
When you're having the test, you're not going to remember it. You don't feel it. You're knocked out. It's 15, 20 minutes of your life, and you go on with things and you recover pretty quickly. I will say the toughest part is doing the prep. So you have to drink a bunch of things and fluid. It kind of clears you out so that you can see on the inside. So you get rid of things. That's what people don't like doing. To be honest, I've done it. I'm of age. I've had my colonoscopy. It's not bad. You can get it done. But I think telling people, and we as a group are trying to put videos out and say colonoscopy is okay and what do you do? But it's getting the message out there that this is a safe procedure. You don't remember it, and it could save your life.
See, I think that's the message right there. And if y'all could just get some different flavors, I would do better as well.
You'd be a millionaire if you came up with something.
I'm going to try to remember that, and I'll come to you to find out what those flavors might be. So, I think it's important that these kinds of messages are in the minority community about the causes. And again, can we talk a little bit about, even though you said it's not identifiable, but what are some of those other diseases that someone might have or conditions that would then even caused them to even really start thinking that I need to start thinking about colon cancer? What are some of those other conditions?
So a lot of different things. It goes along with the risk factors. People who are obese or carry
Okay.
extra weight
There we
around
go.
have a higher rate of getting colorectal cancer. People who have a lot of alcohol and a lot of tobacco in their lives, they're at high risk for colorectal cancer. High blood pressure actually carries a little bit of an increased risk for colorectal cancer as well. So if you have some of these other things that are rampant in different communities, those are things you got to be thinking of even more so, that now if I have symptoms and these diseases, I need to know that. One other thing, again, with the genetic causes, some of these genes, they don't just cause colorectal cancer, they cause other types of cancer. And particularly, there's one syndrome called Lynch syndrome, which is with a particular gene change, where women get endometrial cancer at a rate of about 40 to 60% of women will develop endometrial cancer in their lifetime if they have this gene. So it's not just colorectal cancer in your family, but if you have endometrial cancer or uterine cancer in your family, that's something to say, maybe this isn't right. If someone in my family, mom, had uterine cancer at a young age, should I get looked at for something else? So looking at other cancers in the family, not just colorectal cancer, sometimes is a trigger too.
Right.
So if you do your colonoscopy, and there are polyps, right? Now, do you guys remove the polyps then and then test them? And then if you do have polyps, then how often should people go back for
Yeah.
additional testing?
Yeah, we do. So if we see a polyp when we do this, when we do a colonoscopy, if it's a polyp that we could remove with the scope and we have certain instruments that we can use, we go ahead and take it off there and then. And we send it to the pathology lab where they look at it under the microscope. And we get those results back typically in a week or less. And based on that, we're able to tell the patient, this is what this shows. This is when we recommend you get in another colonoscopy. Now, I will say, we know colon cancer many times starts as a polyp, but many polyps are normal, actually.
That's what I thought.
Many polyps are normal, but we can't tell just by looking at it with the scope what's normal and what's not. So we remove them when we're there anyway. But many polyps can actually be normal polyps without having that increased risk for colon cancer.
All right, that's that. But then, so then after you do find a polyp, what's the time period for when you should go back again? Is there a certain time period? What is that time period?
Yeah, so the guidelines change frequently. They changed a couple years ago again.
Okay.
So it's a normal polyp. We recommend come back in 10 years for another colonoscopy. So pretty nice time frame, right?
Right.
Say it's a precancerous polyp, for example, then it depends on the size of the polyp. It depends on the number of polyps. But typically, we'll have patients come back somewhere between 3 years and 7 years to get their repeat colonoscopy.
Did it used to be 5 years if you had a polyp?
It used to
that's
be
what I'm
5 years.
remembering the last
Exactly.
A
time.
lot
That's
of
right.
it depends. Like anything else, it just depends. So
Yes.
the vast majority, if you don't find anything, which the detection, usually in an average risk population, about 20% of people will have something on the scope. So for the 80% of people, you might not need again until when you're 10 years down the road.
So what are some of the treatments here at the James? I know you talked a little bit about that, Dr. Khalid, but what are some of the, if in fact, someone does, find out they have colon cancer, what are do you do the treatments here at the James?
Absolutely. So I think at Ohio State and the James, we run the whole gambit, to prevention, to education, to identification, and once you have it, then all the different treatment options down the road. We're all one part of team. We're all members of the James. There's radiation oncologists who deliver radiation if you need it. There's medical oncologists who deliver chemotherapy if you need to. There's the surgeons who do the actual surgeries and remove things. And then also with the James, we have a whole support team of things that aren't necessarily medical, but helping people if you need help getting to your appointments, maybe. Do you need help with, some people have chemotherapy, not for colon necessarily, but their hair comes out with certain things. You have wig service, emotional support, wellness, all the other kind of things that go around the total care of a cancer patient are all offered here at the James.
So how do you decide between chemo or radiation? I mean, is it the how bad it is? I mean, how did that?
Sure, that's a great question, and a little bit splits hairs a little bit. So we talk about colorectal cancer. The rectum is the last 9 inches or so of the colon, of the GI tract that kind of comes out your bottom. The rectum and the colon are treated a little bit differently, just by some of the anatomy where it's located. So the rectum's deep down in the pelvis. It's kind of around bones and soft tissues and other things that are really stuck in together. In those cases, if we call locally advanced, so if you have an advanced rectal cancer, those people get radiation usually first.
Okay.
And then depending on if it's gone to lymph nodes or gone to whales, chemotherapy might be part of that option too. For colon cancer, you almost never get radiation for colon cancer. So usually surgery is the first line, unless it's spread to some other part of your body, then chemotherapy usually is the first line. But then after surgery, we determine, like you said, where has it gone? If it's just in the colon wall and nowhere else, that's pretty much it. You don't need to do anything. If it's gone to lymph nodes or gone to somewhere else after the surgery, you find that out, then you get chemotherapy afterwards. So it's all about staging, figuring out where's it gone, how deep is it, how advanced is it.
Very interesting, because I always, you never know. Why do you, I heard you say surgery, but then you just said chemo and then you said radiation.
Right.
So I was trying to figure out how all that works. So again, education is key. Dr. Conte, you keep talking about education.
Yes.
So is this an education process? How soon should we? Especially for young people who think they're invincible. Even, so 40 is the new 30, right? So
Right.
you're talking about 45 years of age. When do you start having that conversation with the 40-something-year-olds? When is it? Or should it start before then?
Right. So ideally it should. So you can plant that seed and people can educate themselves if they choose to, and hopefully they do, about what different options are available. But you want to have that conversation before you're 45, because that is when you should get that first screening done. And if you have a family history of colon cancer, then you probably need to get a colonoscopy before you're 45 if you have some of those genetic conditions that Dr. Khalidi talked about. And if you have some inflammatory bowel disease conditions, those colonoscopies should be happening before the age of 45. But I think part of the education as well, Stephanie, and I mentioned it a little bit earlier, is making sure patients know there are options available. Colonoscopy is one thing, and obviously we're talking about that. But there's stool testing that can be done as well.
Okay.
So there are things that are more convenient for the patient. And again, the most important screening test is the one that the patient is actually going to get done. I can order a colonoscopy every day, but if it's not going to get done, I haven't done the patient any service. But I need to sit down and have a conversation with the patient to say, okay, what's convenient? Maybe you live on a bus line and you take that prep and you're going to the bathroom every hour. Maybe getting on a bus to get here is not what is convenient for you. And you're never going to get it done that way, right? So making sure we meet the patient where they are, I think, is so incredibly vital. And making sure that we are explaining what all those different options are. Colonoscopy is one part. We can test your stool. You can be at home while you do that. You can put it in the mail and send it to us.
Okay.
There are different things that we can do to get you screened appropriately.
Well, I just really appreciate this conversation because I'm learning a lot too, and to be able to communicate this kind of information to people, Black and brown people in the community, is really important, especially because of the increases and the numbers. Those numbers are pretty staggering about the number of deaths here in the United States. So that wraps up our discussion. I'd like to thank our guest for participating today, as well as everyone watching online. And I'm hoping some of you young people that are watching are actually paying attention to this. And you might even want to talk to your parents or your grandparents. For more information on colorectal cancer, including research and care at the James, please visit cancer.osu.edu. Thank you.